A hearty good morning, good evening, good afternoon to each and every one of you. As always, we start on time, so we are going to get this great class started. We have with us today Dr. David Rooney and Dr. Girium Gebreal. Dr. David Rooney is a heart with H-E-A-R-T, a heart of the HCP cure blindness family. He represents the clinical advisor for Ghana, and he's a glaucoma specialist. He also had done a international fellowship through HCP with Dr. Jeff Tabin, one of our co-founders, and then continued to do the great work that he's doing. We are so excited to invite Dr. Rooney and Dr. Gebreal to give our cumulative book review and multiple choice questions today.
Thank you, Dr. Niriani, for that warm welcome. It is great to be with you all again. I think that the easiest structure for this review is going to be to start with a quiz on the content that you all have seen before. So right now what I'm doing is I'm posting a link to a Google form. So please proceed to the link. It'll ask you to put in some information about yourself so we can find you. And remember that the person with the high score on this quiz will receive a 20 diopter and 90 diopter by microscopy lens set. I will start the timer. We'll give you guys about 15 minutes. Again, I'm David Rooney. I'm the HCP Cure Blindness Clinical Advisor for Ghana. I'm a glaucoma specialist. Some of you may remember me from the very beginning of this glaucoma review course that we are doing as a part of the virtual classroom. And if you are still finishing up the quiz, please continue to do so. We won't begin really answering all the questions until a little bit later on in my lecture. So for the time being, feel free to continue taking the quiz, and I will begin doing a bit more review on new content to this review course. So this is the chapter 13, final chapter, which is on surgical management of glaucoma. Now, when we are treating glaucoma, we're really trying to tailor the treatment to the level of damage. Remember that there's 3 general degrees of damage: there's mild, moderate, and severe. And typically what we do is we characterize the severity based on the visual field findings. If you have mild or early glaucoma, it's pre-parametric, which means the standard perimetry shows no damage. However, there is damage on the optic nerve. There's abnormalities consistent with glaucoma. Moderate glaucoma, on the other hand, you have optic nerve damage as well as findings consistent with that damage on visual field testing. And severe, to be clear, moderate is only affecting one hemifield and does not impact a region that's within 5 degrees of fixation, whereas severe, it can affect both hemifields and or encroach on that 5 degrees of the patient's fixation. When you have mild or just even ocular hypertension, the research shows that treatment can reduce the risk of progression to glaucoma. In general, you want to get 20% below the baseline pressure and below 25. Whereas if you have mild glaucoma, you want the pressure lower. You want it down below 21 on average, or see a 25% reduction from baseline in the initial treatment. Moderate glaucoma, even lower pressure, ideally less than 18 and or 30% reduction from their baseline pressure. And in a severe, you want it below 15 millimeters of mercury and or a 30% reduction from baseline. And what we're trying to do with our intervention surgically is to match the optimal surgery to the level of damage, understanding that some treatments have more safe profiles, but also have less efficacy. You wouldn't give a trabeculectomy to someone with ocular hypertension. We don't want to expose them to the risks of all that. Similarly, if you have a patient with a pressure of 45, giving them timolol and sending them home is not acceptable, right? So let's focus on lasers. Initially, there's two basic lasers for trabeculoplasty. The original one is argon laser, ALT. The second is YAG laser, or selective laser trabeculoplasty. SLT tends to be preferred nowadays. It's easier to do. It's more repeatable. It is less inflammatory, but both do work. Here's a difference in the spot size, which is quite considerable. You can see how the ALT has much smaller spots than the SLT. And there's also more microscopic damage to ALT, which can result in PAS, whereas SLT, you see microscopic changes, remodeling about a few weeks after the treatment, but not these burn spots, fewer PAS formation. Both do work, like I said, about 80% of the time, especially in people with more mild disease, and it tends to last about 6 months in 80% of patients. Of those that have a initial response, about half of people maintain a significantly lower IOP for 3 to 5 years. That does drop over a 10-year period to about 30%, but in the case of SLT, it is repeatable, and we know now that it may actually work a little better when you repeat it for patients who show an initial response. Laser peripheral iridotomy is a bit of a different laser. It is a YAG laser, but it's really designed at, instead of it being selective, it's full bore and designed at opening up a hole in the peripheral iris to treat angle closure. Ideally, people have less than half of their angle scarred with PAS. It's important after you do peripheral iridotomy that you recheck the IOP to make sure they don't have a big spike after you create all the debris and inflammation in the eye, and also do gonioscopy in patients with angle closure to see if the chamber deepened. It also will give you a better sense of how scarred up the angle is, how much PAS there is. It's so again mandatory to double check the angle after you treat patients. Now, this will never work if the angle is totally closed by either neovascular membrane or PAS. You're not really able to deepen the angle. The pressure gradient is almost irrelevant if the angle is scarred up. So never do that. Never do LPI in patients with neovascular glaucoma. A more destructive laser still is called a transscleral diode cyclophotocoagulation. You're destroying the trabecular, the ciliary body in this type of laser. And in so doing, you are essentially reducing the production of aqueous. This is reserved for patients with end-stage glaucoma. They have vision that's less than 660 or 6120. And it's because we understand that it can cause vision loss. The treatment is very pro-inflammatory, and while it definitely lowers the pressure, it can cause macular ischemia, and in the long term, hypotony is a risk as the eye continues to become less productive of aqueous. The entire eye can start to collapse. But it is great for patients with blind, painful eyes. Traditional surgeries, cataract extraction. I know what you're thinking. What do you mean? Well, it turns out that when you remove a cataract, you're creating more space in the eye, and that results in a modest, but actually long-lasting decrease in eye pressure. You see the biggest impact in patients who have some component of angle closure, where relief of the angle closure widens the angle and improves outflow through the conventional outflow pathway. Of course, if you have a lens-induced glaucoma, such as phacomorphic, phacolytic, phacoanogenic, this is the primary treatment for those patients. Trabeculectomy is still the gold standard, It is highly cost effective. It is also, even in recent studies, more effective than anything else, and it works on any stage of glaucoma. It can last forever if it's done well and the patient cares for their eye properly. It's revisable. It's modifiable. It works in both angle closure and open angle glaucoma. And you can even do it in patients who still have a lens in their eye. One modification I want to highlight is that you can combine it with SICS or phaco. You can and should also incorporate mitomycin C when you're performing trabeculectomy. This is an antifibrotic, which reduces the risk of failure. Onward for the sake of time. What about tubes? Tubes are great. I love tubes. The best tube is probably, in terms of efficacy, a Barvelt style drainage implant. This is non-valved, meaning it's going to work 100% immediately, which you don't really want initially. So you have to tie off this type of tube with a vicryl suture. It cannot be anything other than vicryl. Don't use imitation polygalactin. It has to be vicryl because it dissolves at a exact time point, 4 to 5 weeks after you sew up the tube and close it off. Vicryl dissolves, in which time you formed a little capsule around the plate, and this prevents hypotony. If you just put this thing in initially and didn't tie it off well, the eye will be hypotenuse, it'll collapse. You have to bring the patient back to surgery. There is a affordable Indian-produced Barvelt knockoff that I want to emphasize is great. This AADI from Aurolab, that's Arvind's arm, costs like 50 or 100 bucks in comparison to many hundreds for the original Barvelt that is still sold. Ahmeds, I love Ahmeds. Ahmeds have a valve that it's supposed to prevent hypotony, but allow the flow out of the eye to happen immediately. It usually works. It doesn't always work. I definitely dealt with hypotony after implanting one of these. One nice thing is that it's easier to implant because you don't have to hook a muscle and stuff it underneath the muscles. You see how the Barvelt style wings, you have to hook the muscles and slip underneath. If you don't do that well, then you're going to have diplopia. Not so with the Ahmed valve. It is a smaller plate. The fact that it flows immediately means that there's often more robust encapsulation, and in comparison trials, it's less effective than the Barvelt by a little bit. I also recognize that sometimes you need the thing to work. You can't wait 4 to 5 weeks for the vicryl to open in a Barvelt. And for those patients, like neovascular glaucoma patients or patients like that, an Ahmed is a great option. Tube versus trab, real quick, the study came out about 10 years ago, and it showed that in patients who'd already had cataract and or trabeculectomy surgery, the Barvelt seemed to be more effective than trabeculectomy with mitomycin C. That is up for debate, depending on who you ask. Also, one quick thing, Barvelts do not need and should not receive mitomycin C. There's no benefit to using mitomycin C with a tube. You'd think there would be, but there's not. So don't waste your time. It can also cause problems like uveal fusions and stuff like that. So only mitomycin C with trabeculectomy. All right. Primary tube versus trab study just came out this month, and it compared Barvelt to trab with mitomycin C as the initial incisional surgery, naive eyes. And after 5 years of study, in the latest finding, it turns out that there's the tube versus trabs are comparable in terms of probability of failure in IOP, with a slight trend toward trabeculectomy being a little better, but the number of meds is significantly different. Trabeculectomy patients tended to be on fewer meds after 5 years. Onward to MIGS. MIGS surgeries are a bit more expensive, and so you're not going to see so many in resource limited countries. However, I don't think you're missing out on a lot. Most of the patients that you see are more advanced and perhaps not such great candidates for MIGS surgeries. MIGS targets 3 different areas depending on the device. The most common path of target is the Schlemm's canal area. You're trying to bypass the trabecular meshwork with stents and things like that. There used to be a device that targeted suprachoroidal space, which I'll get to later. And then the third category is subconjunctival. This is essentially a group of devices that works like a trab or a tube, but doesn't have the plates or the big scleral flap. Speaking of which, the most common one we implant of the third category, the subconjunctival devices, is the Zen gel stent. This stent goes into the AC and then drains fluid into the subconjunctival subtenon space. You can implant it either internally or externally. It does create a bleb, so it really is very much like a tube or a trab. Although it's perhaps a bit safer, the compromise is that it's a little bit less effective. It tends to scar more easily than either of the other 2 classical surgeries, and it's expensive. When you're doing angle surgery, you have to have the right setup because it requires you to look at the angle with a direct gonio lens, as seen in the right. This means that you have to tilt the head away from you at a microscope and then have a microscope capable of tilting itself. Additionally, you need to be able to get your legs underneath it. And by the way, this is pretty much always done from a temporal perspective. So if you have just a flat table, it's going to be real. I mean, you're going to be bending over the table to do this. So again, you just have to have the right setup with a proper ophthalmic surgical bed. Goniotomy. Let's talk about goniotomy. So this is an angle surgery. This is old school surgery, classically best done in pediatric patients, where the trabecular meshwork is kind of the only issue. And it was originally and still done with a needle. Very cheap, very cost effective, and can really work. Part of the problem is that that little incision can scar up. The leaflets between the 2 flaps can scar over time, and so devices have been developed like the Cook dual blade to strip out the trabecular meshwork, as seen in the lower right. It's pretty effective. It can be done in patients with with lenses who are phakic still. It does create a little bit of blood, but usually pretty well tolerated and straightforward and safe. GATS is an even more effective version, in my opinion, of goniotomy. This involves catheterizing Schlemm's canal with a proline suture. You slip it through a small goniotomy and extend it 360 degrees in the whole tract of Schlemm's canal, and then pull through, which makes a 360 degree goniotomy. It's quite effective. It can fibrose in the long term. There's definitely a learning curve with this technique, but when you get the hang of it, it's really good. Canaloplasty is similar, except after you catheterize Schlemm's canal, you inject a bunch of viscoelastic into the canal. It really pops open the downstream pathways from the trabecular meshwork. So Schlemm's canal, all the collector channels really get popped open, and it's nice. This version is called an iTrack, and it's nice because the fiber optic cannula has a little blinking light, which helps you track your progress and lets you know if you get stuck in a stricture or collector channel. It probably doesn't last quite as long as if you do goniotomy, in my opinion. Omni is similar. It's a microcatheter device without the blinking indicator. this slips into Schlemm's canal, goes almost 180 degrees. And then as you pull it back, it injects viscoelastic. You can then reinsert the catheter after you've already pumped up the Schlemm's canal with viscoelastic and then tear through, creating a goniotomy. So in a way, it's a combined GAT and canaloplasty. You pick and choose your course. Your story is, so it's a versatile device. It is expensive. It's many hundreds of dollars. It's fussy to set up. You can only use it once. And long-term efficacy is still not clear in the literature, more than any of the other options I already covered. Trabecular bypass devices. These are more original. What do you think of as MIGS devices? The original one is a iStent. This is a super tiny stent that you slip into Schlemm's canal, and it just stays there. It has a lumen, like a snorkel kind of a lumen that connects the anterior chamber into Schlemm's canal. In my opinion, this thing is almost worthless. It is not very effective because you have to land it directly on a collector channel for it to stay open, to keep Schlemm's canal open long term and have any efficacy. It's just not a great device. Hydrus microstent has a similar concept. You slip a bigger stent into Schlemm's canal, and it does have better data long term in working for mild to moderate glaucoma patients. Downside of this is just it's a big device, and it can end up in places you don't want it to. Like it can create a ciliary, a cyclodialysis cleft. It can create UGH by chafing on ocular structures it's not supposed to. It's also expensive. So cool concept. I do implant them in the US, but it's not the end all be all by any means. Suprachoroidal devices, briefly, this thing was withdrawn from the market about half a dozen years ago in the US. It's a device that's called SidePass. It actually creates a controlled cyclodialysis cleft, which definitely lowers the pressure, keeps everything open, but we found that it caused corneal decompensation in the long term, and so it was removed from the market. Nothing has come back into this space in the US per FDA rules, but very effective location for MIGS. I am going to lightning speed 7. You've all seen this before. I'm going to hit some high points. Glaucoma has it's a classic progressive optic neuropathy. It has a very specific pattern of nerve loss. It's caused by multiple things. So it's a wastebasket term, meaning there's a bunch of other things diseases that are bundled up into glaucoma, with the end being this optic neuropathy with a classic pattern. IOP is a risk factor, but you can have normal pressure and have glaucoma. We will get into some of the other things later. 2 flavors of glaucomas. There's open angle and angle closure. Here's open angle in the top, angle closure in the bottom. Angle closure meaning that the angle where the trabecular meshwork is closed off by one mechanism or another. So usually there's a pressure differential in pupillary block, at least, where the aqueous gets trapped behind the iris where it touches the lens. And then the anterior chamber just gets smaller as the iris pushes up against the trabecular meshwork. Primary open angle glaucomas, POAG is the most common glaucoma in the world, but you really have to screen for any other cause of OAG. We'll get into normal tension and juvenile later, but just know that if you have POAG before age 40, it's really juvenile open angle glaucoma. Again, POAG is a diagnosis of exclusion in a way, because you have to do so much other screening. You have to be a detective if you are diagnosing glaucoma, because there's a lot of secondary things. You could be seeing a uveitic patient with a herpetic eye disease. You could be seeing steroid-induced glaucoma. You could be seeing lens-related glaucoma. So just diagnosing someone based on pressure and glaucoma nerve findings is not acceptable. You can't call it POAG until you rule out other things in your exam. let's talk about angle closure now. There's a bunch of terms that you need to know. Primary angle closure suspect has apposition, meaning iris touching trabecular meshwork, but there's no elevated pressure or scarring in the peripheral angle. There's also no optic neuropathy. Primary angle closure, there's apposition with elevated IOP and or peripheral anterior synechia, but still there's no neuropathy, meaning no glaucoma. So it's just PAC. Now PACG is just PAC with the optic neuropathy. Finally, acute angle closure crisis is a newer term, but just think of the true emergency closed angle patients. Things close quickly. They develop a classic headache, halos, nausea, vomiting, pressure in the 50s. Those are patients who will come in hot, and you have to do something to break the attack. Secondary angle closure glaucomas. Just think, all right, there's two categories of secondary angle closure, meaning this isn't just sort of an anatomical thing that happened. In a sense, there's a reason for it. So under pupillary block, category number 1, you have lens-induced. The most common one you're going to see is phacoemorphic. Huge lens, older patient, blocks off the angle structures, got to get the lens out. You could also have other things happen like ectopia lentis, the lens shifts forward. I'll skip over the rest. Non-pupillary block, category 2. There's 2 mechanisms for non-pupillary block. You can have a pulling mechanism. That's like an evascular membrane where the iris is pulled over the trabecular meshwork. There's also a pushing mechanism. This is less common, but you can have, for example, a big mass or swelling like in the ciliary body, uveal effusion, aqueous misdirection. The vitreous cavity swells up and pushes everything forward, closing off the angle. Genetics are important to know. Think about genetics as if you have a patient in front of you who you're diagnosing with something weird, like Axenfeld-Rieger syndrome. They need to know what to tell their kids or if they should have kids, right? Most glaucomas are more complex inheritance, like POAG. We know there's an elevated risk if you have a family member, but the most testable and useful types of genetics are the ones that are autosomal dominant, autosomal recessive. For example, question 1, which of the following genes is associated with JOAG? Tiger, now called mycilin. I'll let you review the other common ones that are tested. I listed down at the bottom. Here's a great chart inside the BCSC book, useful to look at before quizzes and just to know this stuff. IOP and aqueous humor dynamics, chapter 2. I think the most useful thing to know is that the eye makes 2 to 3 microliters a minute, and the anterior plus posterior chamber is about 200 to 300 microliters in total volume. Therefore, the eye turns over aqueous in the front of the eye about every hour and a half. This is useful if you are trying to tap an eye and then let it reform, expecting the pressure to go back up at around 100 minutes afterward. All right, 2 pathways for aqueous humor outflow. There's a conventional or the trabecular outflow and the uveoscleral or non-conventional. The TM outflow is pressure dependent. Higher pressure, faster flow. Uveoscleral, pressure independent. This fluid is constantly going at a constant rate through the ciliary muscle. Know that of the 3 types of trabecular meshwork, the highest resistance is in the juxtacanalicular. That's the most inward portion of the TM right next to Schlemm's canal. Aqueous humor dynamics, got to know the Goldman equation. Here's the question related to it. According to the Goldman equation, what is the ratio of the increase in IOP to the increase in the episcleral venous pressure in millimeters of mercury? Looking at the formula, you can see that little PV at the end. It's a 1-to-1 with the IOP. So if you have high episcleral venous pressure, you're going to have high eye pressure at a 1-to-1 ratio. Sources of air. This is very practical knowledge, so know this cold. Question related to it. Which of the following correctly describes an applanation tonometry error and its cause? You can have a falsely elevated IOP if you have a lot of fluorescein and wide mires on your applanation. I'll let you review the other ones that I listed below. Clinical history. Make sure that you're not just asking them about, if they've had a family member of glaucoma, but also think about systemic disorders that could be related. Medications can cause glaucoma as well. And ask about trauma. The related question, which of the following medical conditions in a patient with glaucoma should prompt further investigation of a potential medication-induced glaucoma? Asthma, COPD. Why? Because of steroids. They often take a lot of steroids, and that can create steroid-induced glaucoma. Super, super common and under-recognized. It's a big deal for patients who also have baseline POAG because compared to the average population, where 1/3 of patients respond with elevated IOP to steroids, people with POAG have almost 100% chance of responding to steroid if they're on long-term steroids, especially topical ones. Clinical evaluation of the anterior segment. I'm going to blitz through this. Just know you have to look at the unexpected things like the refractive error to help identify things, as well as any sort of phacoematosis type non-ocular findings like tubers and things like that. Pupillary function is important. Check for APDs in patients with asymmetric glaucoma. Slit lamp, I'm going to skip through. Gonioscopy is so critical. You must do gonioscopy on every single glaucoma patient. And so it's important to know what you're looking for with gonioscopy. This is the only way to know if they have a closed angle or an open angle, which dramatically changes the treatment. There's two forms of gonioscopy, direct and indirect. This is, all right, question 5. What's the most important factor in determining when to perform a laser peripheral iridotomy in an eye with a narrow angle? Well, you got to know if it's a narrow angle, right? So we covered that at the very beginning of the lecture. You have to know what the angle looks like, how much scarring is there, is it going to be useful? So number 1, use gonioscopy before you do an LPI. All right, onward to posterior segment. We are going to zip through this as well. Just know that there's a bunch of classic findings for glaucoma. They all are structurally related to the optic nerve because of this extension of the RNFL from the optic nerve and these bundle fiber patterns, right? If you see this notch and a disc image, this patient has glaucoma. And here's a picture of a notch without the disc image that's gone away. And here's your defect. You can see it even in yellow light. And now topographically connecting the structure and the function, you can see the relationship between the scotomas and the pattern of the RNFL. So one more picture of common things. We'll skip over the imaging to a large extent. Just know that OCTs are super useful because you can quantify the amount of nerves, the RNFL, and trend that over time in a highly reproducible manner to track if someone's losing nerves. You can also follow the macula, which thins out as the RNFL dies. In healthy subjects, what's the average annual rate of change in the thickness of the peripapillary RNFL on the OCT? The correct answer is B. Normal people lose nerves over time. It's just real slow. It's about 0.5 micrometer per year. So if you're comparing an OCT from 10 years ago to now, you'd expect them to have about 5 micrometers average RNFL loss, just at all comers. Anything more than that, you should be concerned about glaucoma. Question 7, what optic disc characteristic is most specific for glaucoma? It's focal notching of the rim. All the others can happen, but the big classic one and the one that shows up real early is notching of the rim in the superior and inferior locations. Perimetry, very quickly. I love this slide. It helps you understand the difference between a 24 and a 10-2. You see the 10-2 in green. It has so many more points in that central area. This is great for patients with advanced glaucoma. Difference between mean deviation and standard pattern standard deviation is really important to know. Mean deviation is just a global average. The whole mountain is shorter, right? Pattern standard deviation is picking up on those classic glaucomatous defects, like the superior or inferior defects. They stand out more than the rest of the mountain. You have big cavitations, in a sense, in the pattern of the loss. And so this is useful in helping to identify glaucoma. There's a lot of things that can create a reduction in the mean deviation. For example, cataract can just reduce everything, whereas a more staggered loss of visual field functioning is consistent with glaucoma. Visual field interpretation, know how to look for reliable indices like the fixation losses, false positives and negatives. Know your scotomas. This is a great slide for reviewing all of them, albeit on a gold mob visual field, which is less common, but still good to see. Common types of glaucomatous field defects here, showing the structural change to the functional change on the visual field. Now, question 8, when is a false negative error recorded in perimetry? False negatives are when on retesting, the patient just simply doesn't respond to a stimulus that they had previously said, oh, I see that. This is often when they're just kind of falling asleep. But sometimes people with glaucoma do have more false negatives. And so because of that, we tend to allow a little more false negatives and false positives. Up to 25% of false negative response rate is still acceptable on standard automated perimetry. Question 9, what's a corresponding visual field to superior pattern of RNFL loss? An inferior nasal step is the correct answer. Let me show you. All right, superior field loss corresponds to inferior field change. So if this is your OCT, down at the bottom, A is going to be your answer. It's also useful to know which eye you're looking at on the visual fields. Just remember that the arrow for 24-2 points to the nose. Chapter 7, primary open angle glaucoma. Very quickly, there's POAG, glaucoma suspect, ocular hypertension, and normal tension glaucoma. We already covered POAG to a large extent. Glaucoma suspect, anyone that has something suspicious, like the optic disc or RNFL, visual field that's suspicious but not so clear-cut, and perhaps they have a little bit of elevated eye pressure, which you could also call ocular hypertension. Ocular hypertension, they got elevated IOP, but nothing else going on in terms of the testing on the nerve or the visual field. This is super common. In the US, it's estimated that maybe even 8 times more common than POAG. So if it's that common, should you treat it? According to the Oates study, if you treat POAG, it does cut the risk of, if you treat ocular hypertension, it cuts the risk of developing POAG in half. But 9 times out of 10, patients with ocular hypertension don't even progress without treatment at 5 years' time. Onward, normal tension or low tension glaucoma. Yes, you can have low tension or normal tension and glaucomatous changes that are progressive. Tends to be bilateral. You often see a very deep cup and disc hemorrhage, and central scotomas show up earlier on in general. So these are pretty scary because they can lose central vision surprisingly quickly. You have to rule out other optic neuropathies, though. So just a quick slide down here for differential diagnosis for other optic neuropathies. For example, someone may have optic nerve drusen or an ischemic optic neuropathy that mimics POAG. Sometimes I see POAG and I'm worried about neuro issues, and I have to get an MRI on patients to rule out a mass or something like a pituitary adenoma, which wouldn't elevate the pressure but still cause an optic neuropathy. All right, I'm going to skip through my bonus questions. Last question related to the last chapter I reviewed. This is a super high yield slide. It's also a chart from your BCSC book. This is all about after a trab. This is the pressure, this is the appearance, what's going on, what do you do? And the related question, 27-year-old myopic man with advanced JOAG shows up a day after he did a trab with mitomycin C. On your exam, you have a patient with a pressure of 45. The blood's flat though, and there's a shallow AC. So which of the following is the most likely diagnosis? This patient probably has aqueous misdirection. And the telltale is that you have a flat blood, high pressure, and the chamber's collapsed. Now, if you had, for the sake of time, I won't go into all the other things that I listed below, but just know that this is really useful for any glaucoma surgeon to know cold. Here's the flow chart. And at this point, for the sake of time, I'll turn it over to Dr. Girium for his portion of the review.
Many, many thanks to you, Dr. Rooney, for a fabulous, fabulous session. And Dr. Girium, over to you.
Thank you very much. Good evening and good morning, depending on where you are. So I have prepared some questions from chapters 8 to 12. I'll go through the questions and I'll try to include also some descriptions about the questions. So I'm Girium from St. Paul's Hospital Medical College in Ethiopia. I am an ophthalmologist and glaucoma specialist. First question was, which clinical parameter doesn't differentiate primary open-angle glaucoma from pseudo-exfoliative glaucomas? So lateralities, IOP pattern, response to medications, or outcome of trabeculectomy. So the answer is D, outcome of trabeculectomy. So there are different parameters that differentiate between POAG and pseudo-exfoliative glaucomas. That's very important to know. If you see the geographic areas, pseudo-X glaucomas are common in Scandinavian areas. No specific racial risks, but if you see primary open-angle glaucomas, they are more common in sub-Saharan African descent, people of African descent, and Hispanics. And the age is another differentiating factors. Age, 40 years, is generally a dividing line to diagnose primary open-angle glaucomas, although it is commonly known that it has early onset in sub-Saharan Africas. But pseudo-X glaucomas is strictly age-related and very rare before 50 years of age, and commonly you see it after 60, 70 years of age. Laterality, POAG is a bilateral disease, although it may be asymmetric, and the asymmetry may be in the form of, for example, ocular hypertension in one eye, early glaucoma in the fellow eye, or early in one eye, moderate in the other eye, and so on. But it is not unilateral, it's bilateral disease. But in pseudo-X glaucoma, it may occur unilaterally. Of course, it may occur bilateral, but unilateral is, if you find it, it will be more likely pseudo-exfoliative glaucomas. And typically very asymmetric, like one eye having ocular hypertension, in the fellow eye having advanced glaucomas, and so on. The IOP pattern is, in general, is greater than 21 in POAGs, but the same for pseudo-X glaucoma, but highly notable in pseudo-X glaucoma is not only the level of increased IOP, there's greater diurnal fluctuations as well. So this is very important to know in choosing which type of medications or treatment option in general, because your office visit intraocular pressure may not reflect, the overall intraocular pressure the eye is going through during the follow-up periods. Response to medications, pseudo-X glaucoma is known to be poor responders. They are poor responders. And for laser trabeculoplasty, it's effective in both of them, but peculiar to pseudo-exfoliative glaucoma is, the effect may be short-lived, yeah? Not only with that, with the pigmentations, less amount of energy is required in terms of CDX glaucomas. So trabeculectomy, there are some studies showing due to the increased incidence of post-op inflammation in CDX glaucomas, the outcome may be less, but systematic reviews have not shown any difference in the outcomes of trabeculectomy between these two groups. The overall prognosis is much worse in terms of CDX glaucoma as a result of those factors. Steroid response is another factor because, as Dr. David previously mentioned, nearly 95% of patients with POAG are steroid responders. But many studies show that, CDX glaucoma, CDX fellowship glaucoma patients is the same as, those patients without glaucoma, nearly 1/3. So you have to be very careful in the use of steroids in patients with primary open angle glaucomas. So talking about angle pigmentations, it's very important to know also pigmentary glaucomas, differences between the two. CDX is the same in both genders. Pigmentary glaucoma is more common in men than human. You find pigmentary glaucoma earlier, let's say it's like 20 to 50 years. And we have to note that in pigmentary glaucomas, with increasing age, the signs of pigment dispersion will decrease due to the development of relative pupil block. So the course may be, better later in life. They have the same feature of high IOP with wide fluctuations also diurnally. Gonioscopic features between these two, there are two clinical conditions associated with high angle, heavy angle pigmentations. It's very important to know that, the pattern is a bit different. In case of pigmentary glaucoma, we found the pigmentation to be, homogeneous, dense, but in case of serioxylitic glaucoma, it may be patchy and sometimes in a variegated fashion. Iris features are a bit different in these two, also particularly the transillumination defects. Yeah, you find this transillumination defects in mid-peripheral iris in pigmentary glaucoma as a result of the rubbing of the iris by the ciliary processes. But in case of serious glaucoma, it's peripapillary transillumination defects. And gonioscopically also, the peripheral iris, you will note that the concavity, the concave change of the iris in pigmentary glaucomas. The same with outcomes of surgery in both cases, except that, the poor medical response to medication in terms of serious glaucomas. But particularly these two, they respond to lasers. The problem is the response is short-lived. And, due to the pigmentations, the high pigmentations, usually you need lower amount of energy when you are doing trabeculoplasties. When I am saying laser, it is laser trabeculoplasties. So the other question was which drop was associated with lower risk of raising IOP. So the answer is C, difluprednol. Steroid response. Steroid response is one of the common secondary open angle glaucomas with prolonged use of steroids. Any form of steroid use, eye, periocular, ocular, intravenous injections, or systemic like ocular or even dermatologic applications may be associated with steroid glaucomas. Nearly 1/3 of populations with glaucoma have steroid response. It's very important to know that, the type and potency of the agent and also the means of frequency of administrations. And, this affects the IOP rise. So if you consider intravitreal injections, they are associated with higher risk of secondary glaucomas, okay? And if you consider the potency of the medications, okay, they vary, and those medications known to have been associated with lower risk are this loteprenol, formoterol, flucones, remexolone, and meridosone. So in those patients who are at higher risk of steroid response glaucomas, these are the preferred steroid medications. Those patients who need to use the steroid for longer period of durations, you have to be very careful in the selection of these medications. Risk factors for corticosteroid-induced glaucomas, not only on the presence of POAG, family history, first-degree relatives, very young age or old age, connective tissue disease and diabetes and myopia. These are also risk factors for POAGs. So the other question was a 38 years old female patient who was referred into your clinic following a high IOP reading. On examination, you found out the IOP on the right eye was 17, the left was 35. The left eye appears paler and has stellate keratic pressure across the whole corneal endothelium. She has some circulating cells in the anterior chamber. So which one is true among the following? That was the questions. Notable features in this are the age, 38 years old. The high intraocular pressure measurement in one of the eyes only, unilateral features. If you see the iris appearance is different between the two eyes, there is an occurrence of keratic precipitates, which is stellate and which is occurring also in the whole corneal endothelium. So this is typical for Fuchs-Suveti syndrome. So the answer for this question is the cataract surgery is associated with an increased risk of intraoperative bleeding. This is the answer. So this is a chronic form of uveitis. It is typically unilateral, affecting middle adulthood, and patients are usually asymptomatic, with low-grade anterior chamber inflammations, posterior subcapsular cataracts. That's not associated with posterior synechiae. There are some stellate capes distributed all over the corneas. Some may have anterior vitritis. Okay, patients may have secondary open-angle glaucomas in 15% of the cases. So they have some multiple fine vessels that cross the trabecular meshwork, and this may bleed during lens extractions. Typically, they don't lead to peripheral anterior synechiae formation. Also, we don't have secondary angle closure. So it is secondary open angle glaucomas. Corticosteroids are not generally recommended because of the low-grade inflammations, and it's not effective also. Rather, the use of the steroids may be a risk factor because it may elevate the intraocular pressure. So the answer is that, the patients may have bleeding intraoperatively during cataract surgery. That's what we call Amsler's sign. So the other question was, which of the following is correct about angle recession glaucomas? So represented here, elevated occur, laser trabecular has good efficacy, pilocarpine may be useful, second-line medication. So the answer was, elevated IOP may occur in the fellow eye. So this is a chronic and usually, so one of the entities that we may miss if we are not using gonioscopy routinely is angle recessions. It may occur, in some months or even 25 years or more after the injuries. Some patients may have, half of patients, they may have elevated IOP in the fellow eye. So laser trabeculoplasty is not effective, it has reduced efficacy. Myotics also, okay, they may be useful, but usually some patients, they may have paradoxic response to increased IOP. One, as a result of, decreased uveous scleral flow associated with myotics. And also, as a result of the trabecular meshwork injury there, you will not have an increased outflows through the conventional pathway. It's important to know what the angle recession is. I have a good diagram here to show you to differentiate between these terminologies. When you have, injury into the trabecular meshwork, that's one of what's happening after blunt injuries. When the whole of the ciliary body is detached from the scleral attachment, so we call it cyclodialysis. But angle recession, when the longitudinal muscle is separated from the rest of the ciliary bodies. Some patients may have, zonulolysis. Some may have iridodialysis. Typically in angle recessions, it's not simply the angle recessions that gives rise to increased intraocular pressure. There are associated injuries into the trabecular meshwork. That is one of the main factors that leads to increased intraocular pressure following injury into the anterior segments. So the other question was a 54 years old female who came for written exam. IOP was 26, the fellow was 25. So the answer for gonioscopy is iridotrabecular apposition in 2 quadrants. Nerve is okay, visual field is okay, which correctly demonstrates. So the answer is primary angle closure. So Dr. Rooney, I think, described it well. So usually 3 quadrants at least iridotrabecular apposition is there to lead to increased IOP. But we know with increased intraocular pressure, one of the end organ changes in the process in the pathophysiology of angle closure is there. So we call it primary angle closure. When you don't have any such end organ changes like Seneca formation, pigmentary changes, or raised IOPs, that's where we call it primary angle closure suspects. So don't forget this European Glaucoma Society classification of angle closure to differentiate between these different items. Patient is a patient who had undergone previous laser iridotomies. So you wanted to do cataract surgery, so you found out that the axial length is 19.5 millimeters. So which one procedure should be considered in addition to the cataract surgery? So the answer is the posterior sclerotomy, prophylactic. Okay, so with this is a patient with non-ophthalmos. Patients with non-ophthalmos have an eye which is normal in shape, but usually small in the size, particularly the axial length is less than 20 millimeters. The lens size versus the overall eye size is, exaggerated. Patients also have thick sclera, which impairs drainage of from vortex veins. Angle closures, glaucoma of angle closure types are very common. And the safest and best way to manage such cases is with medical therapy, with iridotomies, as well as iridoplasties, because intraocular surgery is frequently complicated by choroidal effusions and non-rhegmatogenous detachments. So in such cases, it is recommended that prophylactic laser posterior sclerotomies be done, because this decreases the risk of intraoperative and postoperative choroidal effusions. You can consider goniosynecholysis if the patient has goniosyneche, primary, okay, syneche, or posterior pars plana vitrectomies in some cases may be recommended when you are doing cataract surgery, when the anterior chamber is very shallow, difficult to do the FCOph, for example, as a kind of deepening. You may consider that, but the very important step in such cases is the prophylactic posterior sclerostomy in such cases. So the other case was a 75-year-old patient who presented with 1 week history of right eye pain. Important to know that this patient is old, one eye problem, hypermature cataract. That means it was a long-standing one. There is raised intraocular pressure. There is a deep chamber. Cells and flares are there. We are not, told about the nature of this KPs and so on. Okay, there is no KP descriptions. So this is typically, phacolytic glaucoma. So I'll go through fast. Lens-induced glaucoma, lens can cause, open angle as well as angle closure glaucomas. Open angles typically are phacolytic, phacoantigenic, and lens particles. The angle closures may be phacomorphic, and subluxation of, for example, in situ exfoliation glaucomas anteriorly, which may lead to, people block mechanisms. So phacolytic, I will go through it, is when in patients who have hypermature cataract as a leaking function, so there is leakage of lens materials through an intact, lens capsule through microscopic openings. The mechanism is that macrophages engulf these materials, and macrophage engulfing these lens materials will block the trabecular meshwork, leading to increased intraocular pressure. So typically patients don't have history of trauma or surgery in such cases. But the other two, particularly phacoantigenic glaucomas and also lens particle glaucomas, they have history of trauma or surgery and the lens matter. In the case of lens particle glaucomas, that's obstructing the outflow. That is the main factor in increasing the intraocular pressures. But in phaco-antigenic glaucoma, it is immune reaction, typically granuloma causes type of inflammation as a result of the lens matter that results in the increased intraocular pressure, secondary glaucomas. So, which of the following statements concerning primary congenital glaucoma is true? These are the choices given. So, the answer is B, approximately 25%. They are neonatal onsets. So primary congenital glaucomas is sporadic. Yes, they are familial in some cases, but it's 10 to 40% of cases, and with autosomal recessive inheritance patterns. The newborn onsets account for around 25%, which may be, you know, occurring at birth or within the first 4 weeks after birth, but nearly 80% they are diagnosed in the first year. In the early phases, the glaucomatous cup is enlargement is circumferential. It's not, you know, like the older children or not like the older, like adults, not preferentially affecting the superior and inferior rims. So the cup general enlargement is, you know, circumferential because the scleral canal is uniformly stretched with increased intraocular pressure. So, of course, meds general anesthetics like halogen and so on decrease the intraocular pressure, but ketamine, which increase the muscle tone, it will increase the IOP. So, so ketamine is associated with increased intraocular pressures. I'll go through the other questions like medications. A patient with elevated IOP on left eye, persistent corneal edema 1 year after surgery. The IOP was 25, so which of the following is contraindicated? So what we know is that, you know, it was 1 year after surgery. It is as a result of most likely endothelial failures, pseudophakic bullous keratopathies or aphakic bullous keratopathies. You know, in such cases, you know, dorzolamide, you know, carbonic anhydrase inhibitors, because they are also present in the corneal endothelium, they may make the corneal, you know, edema worse. Be careful also on the use of latanoprost. If you are told that there is, you know, vitreous loss and so on, the patient is aphakic or something, you know, the risk of CME may be higher with the use of latanoprost. Corneal edemas. Corneal edemas are mainly as a result of maybe associated with dorzolamide. So this is a patient with presented with red eye and irritations after initiation of medications with follicular conjunctivitis. So I think, you know, this that it is premonitory, which is typically associated with a higher risk of development of follicular conjunctivitis. So in patients with high hypermetropia and or very short axial lengths, which of the following procedures is known to cause aqueous misdirection or malignant glaucomas? What do you think? Is it cataract surgery, peripheral iridotomies, trabeculectomy, or all of the above? So the answer is all of the above. So malignant glaucomas, particularly in patients with hyperopias, it may occur even spontaneously, okay? Or it may occur with initiation of meiotic therapy. Those of us, you know, who have one of the armaments, you know, available medications, pilocarpine, were very careful when you are initiating meiotic therapies after trabeculectomies, okay? Well, that's one of the areas where you have the onset of the malignant glaucomas. So it may even occur spontaneously as well. Clinical features typically are myopic shifts with very high intraocular pressure elevations. The chamber is shallow or flat. Typically, unlike with pupillary block and other types of post-op complications, you know, the center as well as the peripheral chamber will be uniformly shallow. That's one of the differentiation factors. The other differentiation point is there is no component of pupil block. So you may see a patent peripheral iridotomy, okay, iridotomy in that patient. So even sometimes when you are not sure that there is no PI patent, so you may need to do, a PI to, to differentiate the component of existence of pupil block. So management, so you have to differentiate other clinical parameters like pupil block or, suprachoroidal hemorrhage in the post-op periods and so on. Medications, typically conservative managements are use of atropine, aqueous suppressants. This usually lead to resolution of the problem in like nearly 50% of cases, but some more patients who are resistant to this treatment, they may need, some more interventions. One of these is iridotomy through an existing peripheral iridotomy, or some patients may need, with surgical peripheral iridotomy or posterior pars plana vitrectomy also sometimes. Okay, so it may occur mainly in patients with hyperopia. It may occur spontaneously, mostly after surgery, or any type of laser treatments like iridotomies, even cataract surgeries, and so on. This may all be predisposing factors. So under anesthesia, a 6-month-old boy is found to have corneal diameter of 13 and 12.5. So significant bilateral corneal edema is also present. Intraocular pressure are 33 and 39. What would be a preferred first-line treatment in such cases? Notable here is the corneal enlargement, okay, for a 6-month-old boy. This is, big corneas bilaterally. This patient has bilateral corneal edema. So the answer is trabeculotomy. So surgical intervention is the treatment of choice, unlike adults in primary congenital glaucomas. So trabeculotomy is preferred in case of poor visualization as a result of corneal edema and so on. Goniotomy, trabeculotomy, the outcome, they are the same. There is no evidence to show that one is superior over the others. But for doing goniotomy, it involves incision of the trabecular measure, and so direct visualization is very important. So for this particular patient with hazy cornea, so trabeculotomy is the first line, treatment. Trabeculectomy, poor success in such cases. Cycloablations, reserved mainly for patients who have poor prognosis, for failed, trab goniotomies and trab failed tubes. So even with addition of medications, when the patients are not responsive, cycloablation, particularly the diode laser cyclophotocoagulations may be added. So for this patient, trabeculotomy is the one. So thank you very much.
Thank you all for participating in this review. And for those of you who also participated in the quiz, I'd like to make the announcement that we have a top score. It is Dr. Gebreal. He is from St. Paul's in Ethiopia. I believe that Dr. Girium and Dr. Mola know each other well. And he's, as we say in the US, a chip off the old block when it comes to glaucoma knowledge. So Dr. Mola, we will be in contact by email, and we will help coordinate your receipt of those lenses. Thank you all so much for your time and attention. And if you have any questions, please feel free to reach out to me, Dr. Nariani or Dr. Girium.
Thank you very much to Dr. Rooney and Dr. Girium. Lovely, lovely. Thank you, everyone. Stay tuned. So in 2 weeks from today, you will have Neuro-Ophthalmology Part 1. You all should have the book. So next time, Dr. Courtney Francis from University of Washington will be teaching you from the 2021 to 2022 book of Neuro-Ophthalmology, chapters 1 through 3. So get set for that. Many thanks to Dr. Rooney for the generous gift to the residents, and congratulations to Dr. Mola. Dr. Girium would be so proud. Thank you, everyone.